Hello friends, welcome to my YouTube channel. Today I am going to start with general medicine. First topic is adrenal insufficiency and hyperaldosteronism. Addison's disease occurs due to autoimmune adrenalitis. It is the most common etiology of primary adrenal insufficiency. Patients with adrenocortical carcinoma present with features of adrenocortical hormone excess, that is Cushing syndrome. Hypernephroma and medullary carcinoma thyroid are not associated with Addison's disease. Tuberculosis is the most common cause of adrenal insufficiency in India and other developing countries. Idiopathic atrophy due to autoimmune condition is the most common cause in developed countries. Causes of primary adrenal insufficiency includes anatomical destruction of gland, infections like HIV, TB, fungi, surgical removal, autoimmune disease like Addison's disease, polygenic isolated autoimmune adrenalitis, acute hemorrhagic necrosis, that is Waterhouse-Friderichsen syndrome, amyloidosis, sarcoidosis, hemochromatosis, metastatic carcinoma, cytotoxic agents like mitotane, enzyme inhibitors like metyrapone ketoconazole, congenital adrenal hypoplasia, autoimmune polyendocrinopathy syndrome type 1, autoimmune polyendocrinopathy syndrome type 2, X-linked adrenal hypoplasia, adrenoleukodystrophy. Causes of secondary adrenal insufficiency are hypopituitarism due to hypothalamic or pituitary disease and also suppression of hypothalamo-pituitary axis by endogenous steroids from tumor or by exogenous steroids. Elevated ACTH and reduced cortisol levels are seen in primary adrenal insufficiency. It is not a feature of Menford syndrome. The following syndromes are associated with primary adrenal insufficiency. They are autoimmune polyglandular syndrome type 1, autoimmune polyglandular syndrome type 2, AAA syndrome, Smith-Lemli-Opitz syndrome, Kearns-Sayre syndrome, IMAGE syndrome. MEN4 syndrome is associated with CDKN1B gene on chromosome 12. Associated conditions are parathyroid adenoma, pituitary adenoma, reproductive organ tumors like testicular cancer, neuroendocrine cervical carcinoma, adrenal and renal tumors. Next is a case. A 50-year-old woman was diagnosed with Hashimoto's thyroiditis and started on levothyroxine 2 weeks ago. She now presents to your clinic with abdominal pain and dizziness. Her current appearance has shown something different, that is, now she is having skin hyperpigmentation. So the diagnosis is Addison's disease. In Addison's disease, we can see hypoaldosteronism, hypocortisolism, hypoandrogenism, elevated ACTH. The clinical features of Addison's disease include abdominal pain, nausea, vomiting, salt craving, dizziness, postural hypotension, acute kidney injury due to volume depletion, hyponatremia, hyperkalemia, metabolic acidosis, anorexia, weight loss, fatigue, myalgia, arthralgia, fever, depression, postural hypotension, hypoglycemia, hyponatremia, slightly increased TSH, loss of libido, loss of pubic and axillary hair, hyperpigmentation. Levothyroxine can precipitate adrenal insufficiency or crisis in undiagnosed patients. In patients with concurrent adrenal insufficiency and hypothyroidism, a course of steroids must be given before giving thyroid replacement. Hyponatremia is the most common biochemical abnormality seen at presentation in patients with adrenal insufficiency. It is observed in 80% of the patients at presentation. Hyponatremia is caused by mineralocorticoid deficiency and also diminished inhibition of ADH released by cortisol, resulting in mild SIADH during secondary adrenal insufficiency. Hyperkalemia is diagnosed in 40% of the patients during initial diagnosis. Next is a case. A 27-year-old woman is brought to the casualty with severe abdominal pain, vomiting and diarrhea for the past 3 days. She has been excessively tired and dizzy for the past 2 weeks. On examination, there are patches of hyperpigmented skin. BP is 70 by 40 mmHg and blood glucose is 50 mg per deciliter. This clinical scenario is suggestive of adrenal insufficiency. The confirmatory test for diagnosis is ACTH stimulation test or short cosintropin stimulation test. Hyponatremia and hyperkalemia are seen. Plasma levels of ACTH, renin and aldosterone are used to differentiate between primary and secondary adrenal insufficiency. In short, for adrenal insufficiency, first of all, clinical suspicion of adrenal insufficiency by examining the patient by asking whether patient is having fatigue, postural hypotension, weight loss, hyperpigmentation, hyponatremia, and after that we should confirm the diagnosis, that is we should investigate CBC, serum sodium, potassium, creatinine, urea, TSH, and also we should do plasma cortisol 30 to 60 minutes after 250 microgram cosintropin IM or IV. And we should confirm the diagnosis by putting a differential diagnosis by doing plasma ACTH, plasma renin, and also serum aldosterone. After that, we can differentiate it into primary adrenal insufficiency as well as secondary adrenal insufficiency. In primary adrenal insufficiency, we will get high ACTH, high renin and low aldosterone. In secondary adrenal insufficiency, there will be low to normal ACTH, normal renin, normal aldosterone. Next is a case. A 20-year-old woman is being evaluated for adrenal insufficiency. You decide to check her serum levels of ACTH, renin and aldosterone. So, pituitary MRI is indicated in secondary adrenal insufficiency, which presents with the following parameters like low normal ACTH level, normal renin level, normal aldosterone level. Pituitary MRI are not required in primary adrenal insufficiency. The fact that a pituitary MRI is done itself gives a hint towards secondary adrenal insufficiency. Next case is a 33-year-old man collapses during a family vacation. At the hospital, BP is found to be 86 by 52 mmHg and random blood sugar is 49 mg per dl. His wife says that he has been on treatment for Addison's disease 2 years back but had forgotten to pack his medication for the trip. This clinical scenario is suggestive of adrenal crisis triggered by missed medication. In this patient, who is a known case of adrenal insufficiency, IV hydrocortisone is the drug of choice. However, in patients with newly diagnosed adrenal insufficiency, dexamethasone is used for the treatment of adrenal crisis. This is because dexamethasone is not measured in cortisol assays and would not interfere with the diagnostic test, whereas hydrocortisone interferes with cortisol assays. Acute adrenal insufficiency requires the immediate initiation of the following therapeutic strategies, like first one is rehydration, that is saline infusion at an initial rate of 1 liter per hour with continuous cardiac monitoring. Next is glucocorticoid replacement, that is bolus injection of 100 mg hydrocortisone followed by the maintenance dose of 100 to 200 mg over 24 hours. Next is mineralocorticoid replacement, that is it is initiated once daily hydrocortisone dose has been reduced to less than 50 mg, as higher doses of hydrocortisone have sufficient mineralocorticoid action. A patient who presented with an adrenal crisis is undergoing treatment with dexamethasone. Dexamethasone is a long-acting steroid with purely glucocorticoid action. It has no effect on hyperkalemia, which is mediated by mineralocorticoids. Dexamethasone is used in patients with newly diagnosed adrenal insufficiency as it does not interfere with serum cortisol measurement. Next case is a 62-year-old woman who was diagnosed with non-functioning pituitary adenoma develops features of adrenal insufficiency like postural hypotension, hypoglycemia, lassitude. A non-functioning pituitary adenoma causes hypopituitarism due to compression of the pituitary stalk. This results in secondary adrenal insufficiency. This condition is characterized by an alabaster-like paleness due to the lack of ACTH secretion. In primary adrenal insufficiency, hyperpigmentation occurs as a result of elevated ACTH. Addisonian pigmentation is represented by palmar creases. There will be decreased fibrosis. Presence of moles and scars are seen here. Addison's disease causes patchy hyperpigmentation of the oral mucosa. Hyperpigmentation is also present in areas of increased friction including palmar creases, dorsal aspect of the foot and nipples, and also in the axillary region. Bilateral adrenal hyperplasia is the most common cause of mineralocorticoid excess. It causes primary hyperaldosteronism. Other causes of primary hyperaldosteronism are Conn syndrome, that is unilateral adrenal adenoma. Next is glucocorticoid remediable hyperaldosteronism, less than 1%. Other causes of mineralocorticoid excess are as follows, that is congenital adrenal hyperplasia, syndrome of apparent mineralocorticoid excess, adrenocortical carcinoma, Cushing syndrome, progesterone-induced hypertension. Liddle syndrome is due to mutation of ENaC subunits. This results in reduced degradation of ENaC channels, causing prolonged mineralocorticoid action. In Conn syndrome, even though there is volume expansion, an underlying salt escape mechanism leads to the absence of pedal edema. The volume expansion due to hypernatremia leads to right heart dilatation that stimulates the release of atrial natriuretic peptide. This leads to compensatory diuresis and lack of edema despite sodium retention. Features of primary hyperaldosteronism include hypokalemia, hypertension, metabolic alkalosis, polyuria due to ANP, polydipsia due to consequence of polyuria, and also muscle weakness. Next case is a 39-year-old man is referred for evaluation of severe hypertension that has not improved despite being on 3 antihypertensive drugs. The presence of decreased plasma renin activity in this patient would point to Conn syndrome. Conn syndrome is a cause of primary hyperaldosteronism that presents with hypertension and low levels of renin. Elevated aldosterone levels cause negative feedback in the renin-angiotensin-aldosterone system and results in decreased renin production. Hypokalemic hypertension is suggestive of hyperaldosteronism. The screening test of choice is a measurement of plasma renin and aldosterone level to calculate aldosterone-renin ratio. Aldosterone-renin ratio must be estimated in patients with hypertension and any one of the following features like drug resistance, hypokalemia, adrenal mass, and onset before 40 years of age. Prior to the determination of aldosterone-renin ratio, that is ARR, hypokalemia correction must be done. If the patient is on spironolactone, it must be stopped 4 weeks prior to testing. Other blood pressure medication may be continued. ACTH stimulation test is used for the diagnosis of Addison's disease. It presents with hypotension and hyperkalemia. If aldosterone-renin ratio is positive, CT abdomen and adrenal vein sampling are used for confirmation of diagnosis. An elevated aldosterone-renin ratio is indicative of primary hyperaldosteronism. Me-tyrapone stimulation test is used in the diagnosis of adrenal insufficiency. A failure of suppression of aldosterone levels below 140 p-mol per liter indicates autonomous aldosterone production, which is the hallmark of primary hyperaldosteronism. This principle is used in the following tests like saline infusion test, that is IV administration of 2 liters of physiological saline over 4 hours. Next test is oral sodium loading test, that is oral sodium is given over 3 days. Next test is fludrocortisone suppression test, that is it is given IV over 4 days. These tests may be used to confirm the diagnosis in patients with elevated ARR but are not necessary in case of overt hypokalemic hypertension, strongly positive ARR and high aldosterone. Vasopressin acts on the V2 receptor using cyclic AMP as its second messenger. Vasopressin acts on GPCR using different second messengers to accomplish its various actions as follows. By V1 receptor, vasoconstriction using phospholipase C as its second messenger. By V2 receptor, reabsorption of water through aquaporin 2 using cyclic AMP as its second messenger. Vasopressin has a maximum effect on the collecting duct. It acts by inserting aquaporin 2 present in cytoplasmic vesicles of principal cells onto the apical membrane. increased effective osmotic pressure of plasma, decreased ECF volume, pain, emotions, stress, exercise, nausea and vomiting, standing posture, angiotensin II, clofibrate, carbamazepine. These all causes increased vasopressin secretion. Next is decreased effective osmotic pressure of the plasma, increased ECF volume, alcohol. These all causes decreased vasopressin secretion. Cyclic AMP is the second messenger for the hormone secretin. It regulates fluid and electrolyte secretion and also mediates water and nutrient reabsorption. Even though the cytoplasmic receptors are present in the cytoplasm, once the hormone receptor complex is formed, it moves to the nucleus for its action. Nitric oxide mediates its action via cyclic GMP. Cyclic GMP is the second messenger associated with smooth muscle relaxation and vasodilation. Atrial natriuretic factor and nitric oxide are the only hormones that mediate their action via cyclic GMP. Growth hormone is the most abundant hormone produced by pituitary gland. It is produced by acidophil cells or somatotrophs of the anterior pituitary, which accounts for 50% of the anterior pituitary cell population. Vasopressin is produced in the hypothalamus and only stored in the posterior pituitary. Corticotrophs accounts for 10% of the anterior pituitary cell population. Thyrotrophs account for 5% of the anterior pituitary cell population. Cells of the anterior pituitary gland includes basophilic cells as well as acidophilic cells. Basophilic cells are gonadotrophs, thyrotrope and corticotrope. Gonadotrope releases FSH and also LH. Thyrotrope releases thyroid stimulating hormone, that is TSH. Corticotrope releases ACTH. Acidophilic cells are lactotropes as well as somatotropes. Lactotropes releases prolactin. Somatotropes releases growth hormone. Insulin acts on the tyrosine kinase receptor, which is a cell surface receptor. Growth hormone and prolactin are called twin hormones as both are secreted by the acidophil cells of the anterior pituitary. They act on cytokine receptors and show JAK-STAT activity. Thyroid hormone is synthesized from tyrosine residues and thus it is an amino acid derivative. Insulin, activin and parathyroid hormone are large protein hormones. Thyroid hormones and catecholamines are tyrosine derivatives. Serotonin and melatonin are tryptophan derivatives. Nitric oxide is arginine derivative. Steroid hormones are cortisol and aldosterone, estrogen and progesterone, testosterone and also DHEA. Inhibin is a large protein hormone. It is not a steroid hormone. All adrenocortical and reproductive hormones are steroid hormones synthesized from cholesterol precursors except activin and inhibin. Insulin is classified as a large protein hormone as it is composed of 51 amino acids. Protein and polypeptide hormones are classified as small peptides and large proteins because it consists of less than 50 amino acid residues. The action of cyclic AMP is mediated by protein kinases. Cyclic AMP is a second messenger molecule associated with electrolyte secretion and water and nutrient reabsorption. It is synthesized by adenylyl cyclase, but it mediates its action via protein kinases. The binding of epinephrine to its various receptors results in the activation of different types of G protein subunits, namely GQ, GI and GS. All catecholamines act via G protein coupled receptors. This stimulates cyclic AMP production and signaling via protein kinases. Kinases are a subclass of transferases that catalyze the transfer of a phosphate group from a donor to an acceptor protein. They are associated with the regulation of many essential cellular processes. Hyperglycemia is not a characteristic of growth hormone deficiency. Isolated growth hormone deficiency, especially in children, can lead to a higher propensity to develop hypoglycemia. This is attributed to the relatively unopposed action of insulin. Isolated growth hormone deficiency in children is associated with the following features like short stature, micropenis, increased fat, high-pitched voice, high propensity to develop hypoglycemia due to relatively unopposed insulin action. Next is a case presentation. A 3-year-old girl is referred to your center for evaluation of short stature. The child's parents are found to be first cousins. Further evaluation led to the diagnosis of Laron type dwarfism. Laron type dwarfism, which is also known as growth hormone insensitivity syndrome, is characterized by growth hormone receptor anomalies. Laron type dwarfism is an autosomal recessive disorder. The primary clinical symptom associated with this condition is short stature. Treatment is by subcutaneous injection of insulin-like growth factor 1, which is a growth promoting hormone often called insulin growth factor 1. Next case is a 9-year-old girl who presented with short stature is diagnosed with Turner syndrome. The physician decides to initiate treatment with recombinant human growth hormone for short stature. Here, the side effects likely to occur is dose-related fluid retention, hyperglycemia, joint pain and carpal tunnel syndrome, headache, increased intracranial pressure, hypertension, tinnitus, pituitary tumor regrowth, progression of skin lesions, acromegaly, slipped capital femoral epiphysis, gynecomastia. Growth hormone is a potent counter-regulatory hormone to insulin and leads to hyperglycemia, thus contraindicated in patients with uncontrolled diabetes. The actions of growth hormone are: it induces protein synthesis and nitrogen retention, impairs glucose tolerance by antagonizing insulin action, stimulates lipolysis, promotes sodium, potassium and water retention, elevates serum levels of inorganic phosphate, linear bone growth occurs, stimulates epiphyseal pre-chondrocyte differentiation. The paradoxical response of growth hormone release to TRH is not seen in malnutrition patients. In normal individuals, growth hormone doesn't respond to TRH stimulation, but paradoxically, the growth hormone levels may increase in response to TRH stimulation in the following conditions like acromegaly, prolactinoma, anorexia nervosa. The exact mechanism underlying this paradoxical GH response is poorly understood. Next case is a patient presented to OPD with complaints of progressive enlargement of hands and feet and was diagnosed with acromegaly. The most common cause of acromegaly is growth hormone secretion from somatotrope adenoma. Causes of acromegaly are: pituitary cause is of 98%, somatotrope adenoma 60%, which is the most commonest, mixed somatotrope, which consists of lactotroph adenoma and other plurihormonal tumors. Next is extrapituitary tumor producing growth hormone or pancreatic islet cell tumor. Excess growth hormone releasing hormone secretion, central cause is hypothalamic hamartoma, peripheral cause is bronchial carcinoid. Impaired glucose tolerance, galactorrhea and hypertension can be seen in patients with acromegaly. Growth hormone secretion is a part of counter-regulatory defense mechanism against hypoglycemia. Physiological growth hormone secretion is inhibited by hyperglycemia. In acromegaly or gigantism, growth hormone secretion is autonomous and not suppressed by glucose. Thus, its diagnosis can be confirmed by demonstrating the failure of growth hormone suppression with an oral glucose load, that is, impaired oral glucose tolerance test can be done. Galactorrhea is due to hyperprolactinemia and hypertension is secondary to increased aldosterone levels in acromegaly. Growth hormone leads to increased production of vitamin D3, which results in increased phosphate absorption from the intestine and decreased renal excretion. Hence, there is increased serum phosphate level. Next case is a middle-aged man presented to OPD with complaints of difficulty in chewing and a gradual change in voice over the last year. Examination revealed coarse facial features. The image of the patient, that is enlarged hands, point towards diagnosis of acromegaly. Diabetes insipidus is not a feature of acromegaly, but diabetes mellitus can develop in patients with acromegaly. Clinical features of acromegaly are gigantism, prognathism, carpal tunnel syndrome, paresthesia, proximal myopathy, hypertrophy of frontal bones, acral enlargement in hands and feet due to thickening of soft tissues, hyperhidrosis, acanthosis nigricans, skin tags, enlargement of most organs especially the tongue, thyroid, salivary gland, liver, spleen, kidney and prostate, visual field defects like macropituitary adenoma, ophthalmoplegia, headache, low renin with increased aldosterone, diabetes mellitus due to GH-induced insulin resistance, hypercalcemia, hyperphosphatemia, hypercalciuria, hypertriglyceridemia, loss of libido and impotence in males, menstrual abnormalities and galactorrhea, left ventricular hypertrophy or septal hypertrophy, hypertension, obstructive sleep apnea. Diabetes insipidus can be seen as a complication post-transsphenoidal surgery for pituitary adenomas and other cellular tumors, not as complication of acromegaly per se. Clinical features of acromegaly in short: frontal bossing, characteristic coarse facial features and a large fleshy nose, mandibular enlargement with prognathism, coronary heart disease, cardiomyopathy, hypertension, enlargement of liver, diabetes mellitus, increased risk of colon cancer, increased hand size carpal tunnel syndrome, increased foot size, increased heel pad thickness. Next is a case: a middle-aged man. He noticed his shoes are no longer fitting and his finger ring is getting tightened. Insulin-like growth factor 1 levels are elevated. This case presentation mainly points towards a diagnosis of acromegaly. An oral glucose tolerance test with growth hormone level is used to confirm acromegaly. Test for acromegaly includes screening test, the single best test for the diagnosis of acromegaly, which is the measurement of serum insulin-like growth factor 1. A normal serum IGF-1 concentration is strong evidence that the patient does not have acromegaly. Confirmatory test is growth hormone suppression test, that is 75 gram of oral glucose is administered to the patient. Blood growth hormone levels are checked at 30, 60, 90 and 120 minutes after the glucose load. Normally, glucose suppresses growth hormone and it falls to less than 1 nanogram per milliliter. If growth hormone more than 1 nanogram per milliliter, it is diagnostic of acromegaly. Next case presentation is: a 44-year-old man is referred to your center for management of severe hyperglycemia. During examination, you note that the patient has enlarged feet, coarse facial features and prognathism. You suspect acromegaly. The best screening test for acromegaly is the measurement of serum insulin-like growth factor 1 level. Acromegaly is a clinical syndrome that results from excessive secretion of growth hormone. Increased insulin-like growth factor 1 binding protein 3 levels can also be seen in patients with acromegaly, but it is not the screening test. Medical management of acromegaly includes somatostatin analogues like octreotide, lanreotide, pasireotide, growth hormone receptor antagonist like pegvisomant, dopamine agonist like bromocriptine and cabergoline. Before the next case, normal level of prolactin is 0 to 25 nanogram per milliliter. Case is: a 27-year-old woman presents to OPD with infertility and amenorrhea. She also complains of milky discharge from the nipple. Her urine pregnancy test was negative and her prolactin level was 45 nanogram per milliliter. This given scenario of infertility, amenorrhea and galactorrhea with elevated prolactin level is suggestive of hyperprolactinemia, and bromocriptine does not lead to hyperprolactinemia. It is a dopamine agonist and hence it inhibits prolactin synthesis. Dopamine agonists like bromocriptine and cabergoline are used in the treatment of hyperprolactinemia. Drugs causing hyperprolactinemia are atypical antipsychotics like risperidone, phenothiazines like chlorpromazine, perfenazine, butyrophenones like haloperidol, thioxanthines, metoclopramide, dopamine synthesis inhibitors like alpha-methyl-dopa, catecholamine depleters like reserpine, opiates, H2 antagonists like cimetidine, ranitidine, imipramine like amitriptyline, amoxapine, serotonin reuptake inhibitor like fluoxetine, calcium channel blockers like verapamil, estrogens, thyrotropin releasing hormone. These all are drugs causing hyperprolactinemia. Hypothyroidism predisposes to the development of hyperprolactinemia. Both enhanced hypothalamic synthesis of thyroid releasing hormone and increased pituitary responsiveness to TRH have been described as the mechanism behind this phenomenon. Other systemic disorders that predispose to the development of hyperprolactinemia are chronic renal failure, cirrhosis, pseudocyesis, epileptic seizures. The hallmarks of hyperprolactinemia in women are secondary amenorrhea more than primary amenorrhea, galactorrhea, infertility. In men with hyperprolactinemia, diminished libido, infertility, and visual loss from optic nerve compression are the usual presenting symptoms. Next case is a patient presents to your OPD with galactorrhea and amenorrhea. So, TSH should be measured along with the prolactin level to rule out hypothyroidism, which can cause hyperprolactinemia. However, pregnancy using qualitative HCG should be ruled out in all women of the reproductive age group with amenorrhea. Next case is a 30-year-old nullipara with a desire to conceive presents with amenorrhea and galactorrhea. UPT is negative. Investigations indicate hyperprolactinemia. The drug of choice for clinical management of this patient would be bromocriptine. Bromocriptine is an ergot alkaloid and a short-acting dopamine receptor agonist. Due to its short-term action, it is preferred when pregnancy is desired. Cabergoline is a long-acting dopamine receptor agonist with high D2 receptor affinity. It effectively suppresses PRL secretion for more than 14 days after a single oral dose. Prolactin secreting adenoma or prolactinoma is the most common type of functioning pituitary adenoma. Pituitary adenomas are the most common type of pituitary tumor, accounting for 1/3 of all tumors. Non-functioning pituitary adenomas most commonly arise from gonadotropic cells. Pituitary adenomas are classified as functioning or non-functioning based on the secretion of hormones. Non-functioning adenomas are usually asymptomatic in the initial stages, but as the tumor grows larger, mass effect produces clinical manifestations such as headache, bitemporal hemianopia, diplopia, ptosis, compression of pituitary stalk, initially by hyperprolactinemia and in later stages by hypopituitarism. Next case is a 30-year-old woman with a suspected prolactinoma is planned for brain MRI. Pituitary adenoma less than 10 mm are called as microadenomas. Asymptomatic pituitary tumors can be discovered incidentally on imaging. They must also be suspected in patients with features of hormone hypersecretion or mass effect. In such cases, MRI with contrast is the best investigation to detect the tumor. Levels of pituitary hormones must also be measured to rule out both hypersecretion and hyposecretion. Increased insulin sensitivity, low serum thyroxine and TSH levels, loss of secondary sexual characteristic. These all are seen in a patient with pituitary macroadenoma. Pituitary macroadenomas do not cause pigmentation of mucous membranes as ACTH levels are low. In this condition, there is destruction of the pituitary gland by mass effect. This leads to panhypopituitarism or reduced levels of all hormones including ACTH. Excessive pigmentation is only seen in case of excess ACTH. The following hormones are deficient in panhypopituitarism. They are ACTH, which causes secondary adrenal insufficiency, TSH, which causes secondary hypothyroidism, growth hormone, which causes growth failure and adult hyposomatotropism, FSH and LH, which causes hypogonadic hypogonadism, prolactin, which causes lactation failure. Adiponectin secreted by fat cells normally increases insulin sensitivity. It is usually suppressed by cortisol. In panhypopituitarism, decreased cortisol levels lead to increased insulin sensitivity. Superior quadranthenopia may be seen in patients with prolactinoma more than 10 mm in size, that is macroadenoma. In this condition, visual field defects occur due to compression of the optic chiasm. In the initial stages, the pituitary tumor tends to compress the ventral portion of the optic chiasm. This causes a bitemporal heteronemus superior field defect. As the tumor grows larger, the entire optic chiasm gets compressed, leading to complete bitemporal hemianopia. Damage to the optic radiation in the temporal lobe would result in homonymous superior quadranthenopia or pie in the sky appearance. While talking about the visual pathway, the fibers from the nasal half of each retina decussate in the optic chiasm so that the fibers in the optic tract are those from the temporal half of one retina and the nasal half of the other. A lesion that interrupts the optic nerve causes blindness in that eye. Lesions affecting optic chiasma destroy fibers from both nasal hemiretinas and produce a heteronemus, that is opposite sides of the visual field, hemianopia. A lesion in one optic tract causes blindness in half of the visual field and is called homonymous, that is same side of both visual field, and hemianopia, that is half blindness. Occipital lesions may spare the fibers from the macula because of the separation in the brain of these fibers from the other subserving vision. The diagnosis of prolactinoma is highly likely when prolactin levels are more than 200 microgram per liter. The normal range of serum prolactin is 5 to 20 microgram per liter. Prolactin levels are less than 100 microgram per liter, which can be due to non-functioning pituitary adenoma or non-neoplastic causes of hyperprolactinemia. MRI brain must be done in all patients with hyperprolactinemia. MEN2 syndrome is associated with medullary thyroid cancer and pheochromocytoma. The genetic syndromes associated with pituitary tumors include MEN1, MEN4, Carney complex tumors, McCune-Albright syndrome. MEN2A syndrome is also known as Sippel syndrome. Chromosome 10 or RET gene is affected. Associated conditions are medullary thyroid carcinoma, pheochromocytoma, parathyroid adenoma. Next is MEN2B syndrome. It is commonly known as MEN3. Chromosome 10 or RET gene is affected. Associated conditions are medullary thyroid carcinoma, pheochromocytoma. Other associated abnormalities include mucosal neuroma, marfanoid habitus, medullated corneal nerve fibers, megacolon. Next case is a 56-year-old woman presented with a gradually diminishing visual field. She was found to have a pituitary mass and underwent transsphenoidal hypophysectomy. Now she has low levels of ACTH, TSH, FSH and LH. Mineralocorticoid is the hormone supplement which is not needed in the patient post-operatively. Mineralocorticoid supplementation is not needed in patients with hypopituitarism. This is because mineralocorticoid secretion is regulated by renin-angiotensin-aldosterone system, not ACTH. Hence, it would remain intact despite ACTH deficiency. Headache is the most common clinical presentation in patients with craniopharyngioma. Craniopharyngiomas are benign suprasellar cystic masses. They have bimodal distribution occurring predominantly in children but also between the age of 55 and 65 years. It can present with the following clinical symptoms like headache, hypopituitarism, bitemporal hemianopia, raised ICT in case of vomiting papilledema or hydrocephalus. Next case is a 10-year-old boy is referred for evaluation of progressively worsening headache and visual field defect. An MRI brain is done and it showed a suprasellar mass with calcification which is suggestive of craniopharyngioma. Surgery is not curative in the majority of patients as the tumor is adherent to surrounding structures. They are benign epithelial cell containing tumors and are of two types, that is adamantinomatous as well as papillary. Adamantinomatous consists of calcifications and keratin nodules. Papillary consists of calcifications which are rare. Biopsy reveals machinery or motor oil-like fluid within the cyst that contains cholesterol crystals. The treatment of choice is transcranial or transsphenoidal resection. It must be followed by post-operative radiation to prevent recurrence. Pituitary apoplexy does not occur in hyperthyroidism. It is a rare endocrine emergency which can occur due to hemorrhage or infarction of the pituitary gland. It may occur as a result of the following conditions like spontaneous pituitary adenoma, Sheehan syndrome, acute shock, diabetes mellitus, hypertension, sickle cell anemia. Shock is one of the presenting features of pituitary apoplexy. It refers to acute hemorrhagic infarction of the pituitary gland. This results in the compression of surrounding structures by the hemorrhagic mass and hypopituitarism, leading to sudden adrenal insufficiency. The following clinical features are seen, like headache with signs of meningeal irritation, raised intracranial tension, bitemporal hemianopia, ophthalmoplegia, diplopia, cavernous sinus, cardiovascular collapse, that is shock. The investigation of choice is MRI. The treatment is as follows, that is, no signs of raised ICT. We should give high dose of glucocorticoids to correct adrenal insufficiency. If there are signs of raised ICT, then urgent surgical decompression should be done. Loss of consciousness can also be seen, but it occurs secondary to adrenal insufficiency and shock. Growth hormone is the first hormone to fall in Sheehan syndrome. The hormones are affected in the order like growth hormone, then prolactin, then LH and FSH, then ACTH, and at last TSH. Sheehan syndrome refers to postpartum pituitary necrosis following severe postpartum hemorrhage. During pregnancy, the pituitary gland undergoes hypertrophy with increased blood supply. This makes it susceptible to ischemia and infarction when there is severe hypovolemia. The clinical presentation depends on amount of damage to pituitary. That is, mild cases, it can go unnoticed for many years. Moderate cases develops over months and presents like lactation failure, failure to resume menses, mild fatigue and anorexia. In severe cases, endocrine emergency that develops within few days presents as hypotension, shock, severe hypoglycemia, lactation failure. Growth hormone deficiency is very common in Sheehan syndrome because somatotrophs are located in the lower and lateral regions of the pituitary gland and are most likely to be damaged by ischemic necrosis of the pituitary. Next case is, you are a first-year resident in the postpartum ward. During rounds, you see a 28-year-old woman who has been unable to breastfeed since delivery. Her baby was born by normal vaginal delivery that was complicated by severe PPH. Her BP is 90 by 50 mmHg and her pulse is 96 per minute. This clinical scenario is suggestive of Sheehan syndrome. Corticosteroids must be supplemented first as life-threatening manifestations may occur due to the sudden onset of adrenal insufficiency. This is followed by the replacement of other deficient pituitary hormones including thyroid hormone and estrogen administered with or without progesterone. Oxytocin plays a role in milk ejection. It also helps in initiation or facilitation of labor by stimulating the contraction of uterine smooth muscles. It stimulates postpartum milk letdown in response to suckling. Prolactin is the hormone responsible for milk production. Osmoregulation is mediated by hormones such as ADH, aldosterone, etc. AVP or antidiuretic hormone and oxytocin are stored in herring bodies at the axon terminals of the posterior pituitary. They are synthesized by two types of magnocellular neurons in the supraoptic and paraventricular nuclei of the hypothalamus. AVP binds to V2 receptors on the serosal surface, which is also known as basolateral surface of renal tubular cells. This interaction activates adenylyl cyclase and leads to the insertion of water channels called aquaporin 2 on the luminal surface of the cell. ADH secretion reduces when the plasma osmolality becomes low. ADH causes water reabsorption and dilutes the plasma, thereby causing a reduction in plasma osmolality. The antidiuretic effect of ADH is mediated via G-protein coupled V2 receptor that increases intracellular cyclic AMP, thereby inducing translocation of aquaporin 2 water channels into the apical membrane. During and after surgery, surgical stress results in the release of ADH. A mutation in the gene for aquaporin 2 channel leads to nephrogenic diabetes insipidus. Causes of nephrogenic diabetes insipidus are drugs like lithium, amphotericin B, demeclocycline, cisplatin, aminoglycoside, foscarnet, methoxyflurane, rifampin. Metabolic causes are hypercalcemia, hypercalciuria, hypokalemia, hyperoxaluria. sarcoidosis, Sjogren's syndrome, polycystic kidney disease, amyloidosis, vascular causes like sickle cell disease and trait, ischemia, acute tubular necrosis, idiopathic. These all are the causes of nephrogenic diabetes insipidus. Diabetes insipidus is a clinical component of Wolfram syndrome. Characteristics of Wolfram syndrome include diabetes insipidus, diabetes mellitus, optic atrophy, sensorineural deafness. Here the mnemonic is DIDMOAD, DID-MOAD. Wolfram syndrome is caused by mutations of the WFS1 gene. In diabetes insipidus, hypernatremia is observed in the affected patient. Low levels of vasopressin lead to the excretion of large amount of diluted urine. This loss of water from the body leads to hypernatremia. Next is water deprivation test in diabetes insipidus. Procedure is start the test at 4 am by checking the baseline urine osmolality. Deprive the patient of water till 12 pm, that is for 8 hours, and then recheck urine osmolality. The normal urine osmolality is 500 to 850 milliosmol per liter. Next is a case. A man presented with frequent urination and increased thirst. Investigations revealed low urine osmolality and high plasma osmolality. MRI brain was done, which revealed the absence of posterior pituitary bright spot. The given scenario and the absence of posterior pituitary bright spot on MRI are suggestive of central diabetes insipidus. Multiple sclerosis causes primary polydipsia, not central diabetes insipidus. Central diabetes insipidus is caused by a primary deficiency in AVP secretion, which usually results from agenesis or irreversible destruction of the posterior pituitary. It can be differentiated from primary polydipsia with the help of an MRI brain. Next is the approach to polyuria under conditions of unrestricted fluid. If patient is presenting with polyuria, that is more than 3 liters per day of urine, check the urine osmolality. Then if the urine osmolality is less than 300 milliosmol per liter, check plasma ADH. If plasma ADH is more than 1 picogram per milliliter, it is nephrogenic diabetes insipidus. And if plasma ADH level is less than 1 picogram per milliliter, do MRI brain. MRI brain, if it is showing pituitary bright spot present, it is primary polydipsia. And if pituitary bright spot is absent, it is known as central diabetes insipidus. Causes of central diabetes insipidus are neoplasms like pituitary adenomas, which is the most common cause, meningioma, metastasis from lung and breast cancer, sarcoidosis, Langerhans cell histiocytosis, Wolfram syndrome, Hans-Schüller-Christian disease, chronic meningitis, viral encephalitis, toxoplasmosis, granulomatosis with polyangiitis, lupus erythematosus, scleroderma, Sheehan syndrome, aneurysm caused by internal carotid artery, head injury, that is closed and penetrating head injury including pituitary surgery, snake bite, lymphocytic hypophysitis. These all are causes of central diabetes insipidus. Next is a case. A patient presented with frequent urination, nocturia and enuresis. Investigations revealed 24-hour urine output of 7 liters and low urinary osmolality. ADH assay was performed and the recorded values were reported as 1.5 picogram per milliliter. The given scenario is suggestive of nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus develops due to the resistance to the antidiuretic action of AVP. A 24-hour urine volume more than 3 liters is suggestive of polyuria. An ADH value more than 1 picogram per milliliter is suggestive of nephrogenic diabetes insipidus. A patient presents with polyuria and increased thirst. Investigations revealed hypercalcemia. Metabolic derangements like hypercalcemia and hypokalemia lead to the production of large amount of dilute urine by causing nephrogenic diabetes insipidus. Primary polydipsia is of 3 types, that is dipsogenic, which is due to inappropriate thirst, iatrogenic, which is due to an increase in fluid intake due to its presumed health benefits, psychogenic, which is due to psychosis or obsessive compulsive disorder. Diabetes insipidus of central or nephrogenic origin are characterized by low urine osmolality and high plasma osmolality. Next is a case. A 29-year-old lady presented with polydipsia and polyuria. Her symptoms started soon after a road traffic accident 6 months ago. Her blood pressure was recorded at 120 by 80 mmHg with no postural drop. The daily urine output was reported to be between 6 to 8 liters. Clinical investigation results are given below, like sodium 130 milliequivalents per liter, potassium 3.5 milliequivalents per liter, urea 15 mg per deciliter, sugar 65 mg per deciliter, plasma osmolality 268 milliosmol per liter, urine osmolality 45 milliosmol per liter. The most likely diagnosis for the given clinical scenario would be psychogenic polydipsia. The normal range of urine osmolality is 500 to 850 milliosmol per kg, and that of plasma osmolality is 280 to 295 milliosmol per kg. Hence, in the given scenario, both urine and plasma osmolality are low. Along with hyponatremia, it is suggestive of psychogenic polydipsia. Next case is a patient presented with polyuria and polydipsia. She has been on lithium therapy for 6 years for bipolar disorder. Investigations revealed low urine osmolality and high plasma osmolality. The given scenario is suggestive of lithium-induced nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus can be treated with thiazide diuretics. Thiazides reduce the kidney's ability to excrete free water by increasing proximal tubular water reabsorption, which is secondary to volume contraction, and block the ability of distal convoluted tubule to form dilute urine. This effect results in an increase in urine osmolality. Treatment of diabetes insipidus include central and gestational diabetes insipidus. We should give desmopressin, which is an ADH analog. For nephrogenic diabetes insipidus, adequate water intake along with a low sodium diet should be taken. Thiazide diuretics, potassium sparing diuretics like amiloride, which is the drug of choice for lithium-induced diabetes insipidus. Prostaglandin synthesis inhibitor like indomethacin. For psychogenic diabetes insipidus, we should give behavioral therapy to reduce fluid consumption. Fixed specific gravity in which values remain 1.010 regardless of fluid intake occurs in chronic glomerulonephritis with severe renal damage. In chronic kidney disease, as renal function deteriorates, polyuria can be seen due to the impairment of the kidney's ability to concentrate urine. In diabetes insipidus, although specific gravity is low, it is not fixed. Potomania, which is also known as beer potomania or beer drinkers potomania or beer drinkers hyponatremia, it is a specific hypoosmolality syndrome related to massive consumption of beer. Next case is a patient presents with frequent urination, nocturia and enuresis. 24-hour urine volume was measured and recorded to be 7 liters. The urine osmolarity was 260 milliosmol per liter. ADH assay was performed and the recorded values were reported as 0.8 picogram per milliliter. An MRI of the brain was performed and T1 weighted indicated the absence of bright spot. The given clinical scenario is suggestive of pituitary diabetes insipidus.